Good afternoon, all. It's my pleasure to be here at the Health in the Public Interest weekly seminar. I'm the director of the Health in the Public Interest program, along with Adrian Co. Adrian Fuberman. The two of us co-direct the program. You might have heard that the program is coming to an end after this year, but the seminar series is going to continue in a different format. You'll be receiving a letter about it that Dr. Fuberman and I have been working on recently, mostly Dr. Fuberman, and we'll welcome you back next week. And then after that, it'll be September when we start the new format. So welcome, everyone. The Health in the Public Interest program has for 9 years, I believe, been a program that looked at the non-medical determinants of health, healthcare disparities, all the economic, political, et cetera, cultural things that factor into people's health and healthcare. The seminar today is going to be introduced by Priska Hastings, one of our students. She's going to introduce John Hoberman, who is a repeat speaker after a few years absence. And he'll talk for maybe 45 minutes, followed by Priska moderating questions and answers, first from our student participants in the seminar course in the HAPI program, and then by the broader audience. I'm sure this will be a very thought-provoking and important lecture today. So, Priska, the stage is yours.
Thank you, Dr. Myers. As Dr. Myers said, my name is Priska Hastings, and I have the pleasure to introduce Dr. Hoberman. Dr. Hoberman is a social and cultural historian who has researched and published extensively in the fields of sports studies, race studies, and human enhancements, medical history, and globalization studies. His work in sports studies encompasses race relations, politics in the Olympics, and performance-enhancing drug use. His interests include medical history, the social and medical impacts of anabolic steroids, and the history of medical racism in the United States. And so please join me in welcoming Dr. Hoberman.
Thank you very much for your introduction. I'm very glad to be back here for at least the second or third time to talk to students at Georgetown on the subject of what I like to call the racial dimension of medicine. There are a couple of other titles that one could give this talk. One could talk about, race and medicine in American life, which is the title of my course. One could also, and I mean, I've given a lot of lectures on the topic of the racial dimension of medicine. An alternative title would be medical racism, because has been, and there still is an enormous amount of medical racism in the American medical system. It needs careful defining. And at that point, I would refer to a recent lecture that you have heard from Dr. Joseph Graves, who, as you know, is a very prolific and important writer on the subject of race and medicine. The segue here is that Dr. Graves' book is called Why Black People Die Sooner. And that, of course, raises all sorts of questions about the sources of what I'm going to call generically Black medical disadvantage. So that the whole topic of Black medical disadvantage inheres in Dr. Graves' book about why Black people die sooner. Why do they? Why do we have not only racial health disparities, but in some cases expanding racial health disparities? The famous one for the last several years has been Black maternal mortality and the condition of their infants, et cetera, et cetera. That is, a complicated situation that surely has to do with the sort of human environment in the birthing scenario. It is one of a long list of fascinating topics, and it certainly is an example of Black medical disadvantage. In my recent research, I have addressed the issue of Black medical disadvantage by looking the at many studies in the medical journals regarding racial treatment disparities. Now, we all know about racial health disparities, and a great deal of attention has been paid to, where do they come? Why is this happening? It's enormous. There's an enormous socio-historical dimension to that. But there's a couple of, sort of traditional conservative ways of addressing the issue of racial health disparities. And I'm going to get onto the treatment disparities, which in a way are more interesting because if you have racial treatment disparities, that there is very likely physician accountability involved. Now, in the case of racial health disparities, a couple of conservative attempts to account for them, which involves not thinking about the real nature of the racial dimension of medicine, is, oh, those people have inferior genes. I mean, there was actually once a theory that for every medical disorder that Black people contracted, there was a bad gene in there. Another one, and we have heard this from at least a few Republican politicians in recent years, at least one of whom was a doctor, that is, these people just don't take care of themselves. In one case, you had a member of a state legislature who was talking about Black people, or maybe Black and brown people, not washing their hands properly, not wearing their mask. In other words, it's a blame the victim argument. So these are traditional and discredited interpretations of racial health disparities that need to be superseded by more scientific, more intelligent approaches to why these disparities exist. Okay, that by way of introduction, and I will ask you to please advance one slide. All right, that is my book from 2012, Black and Blue, The Origins and Consequences of Medical Racism. So that is the book so far. And as I said, The Racial Politics of Medicine, which is going to be very political and address the enormous imbalance of power between Black people and white people in the United States as the larger context, and address very specifically, in many cases, the big imbalance of power between Black medical personnel and white medical personnel in the American system. Could we have the next slide, please? Now, these are two courses that I have taught. Well, I am continuing to teach Race and Medicine in American Life. It is an undergraduate course at the University of Texas, and I'm hoping that one of the syllabus vetters down at the MAGA-controlled Texas legislature doesn't take a look at the syllabus online, which is mandatory, and say, sorry, this is too DEI. We're going to have to cut this. It did not happen in the fall. I just gave the course in the fall. There was no, I mean, this is a politically interfered with university, the University of Texas at Austin. But I do have to worry a little bit about what is going to be decided up at the Capitol with regarding which courses are allowed to be given, and especially courses on race or race and medicine. They just basically abolished the African American and Diaspora Department, and they mushed it into this globular entity with the Women's Studies program and the Hispanic Studies program. I mean, the erasure of the serious study of Black lives and experience in this society is an ongoing project of the Trump administration. You have to get political about this. The racial dimension of medicine was a course that I taught as an elective for 4 years. The last 3 years, I had the great good fortune of co-teaching that course with Dr. Jewel Mullen, who was the Associate Dean for Health Equity. They have since abolished the program at UT Dell, supposedly a progressive medical school. They did not fire her. But this is the way the wind is blowing. And what I can tell you is that the whole idea of giving a course like the racial dimension of medicine at UT Dell Medical School today would be politically impossible. This now, what I'm pointing to is one of the big frames that I wanted to present because, as I said, I've given many lectures over many years on this topic, and I've had to change the framework of the presentation following the second Trump inaugural in January of 2025. Because there is, Trump is waging a war against the Black population in this country. And this has spilled over into medical life. What's it called? The Commission on Osteopathic College Accreditation has just wiped out anything about quote unquote DEI in more than a quarter of the medical schools in this country. So in other words, the Trumpian politics are affecting medicine. Now, the other great example of that is his appointee, Robert F. Kennedy Jr., who has been doing an enormous amount of damage to the medical establishment. And this has a racial aspect as well. This is 2025, January. RFK Jr. disparaged vaccines dozens of times in recent years and made baseless claims on race. Now, considering that this is a medically unqualified and pseudoscientific mentality, it is not surprising that yet again a powerful white official in the United States is blundering his way into the field of race and medicine. So the report continues. Race also threads through many of Kennedy's comments unearthed by the Washington Post, with several misleading claims about Black Americans, including false claims about Black children's autism rates after vaccination and comments on their immune systems. And then the New Republic, a few weeks later, published an article called RFK Jr. Struggles to Explain Past Quote on Vaccines for Black People. Kennedy immediately began to flail. Quote, there's a series of studies, most of them by Poland, that show that there are particular antigens that Blacks have a much stronger reaction to. There's differences in reactions to different products by different race. Why do I bring this up? Because what the head of Health and Human Services is doing here is that he is recapitulating many, many years of pseudoscientific claims about biological and physiological differences between white and Black human beings. So we're in a new era. And this is only the second presentation of this type that I have given since January of 2025. And then a few months later, you get the appointment of RFK Jr. at the head of Health and Human Services. What I'm saying is that this is a very serious transformation in American medical life, and inevitably, it's going to play out as yet another Black medical disadvantage. And we just heard an example of that by RFK himself fantasizing about racial differences in immune systems, and black people have stronger immune systems, which fits into a long tradition of what I call black hardiness, ascribing heat tolerance and resistance to pain, et cetera, et cetera. So in other words, the American tradition of medical fantasies about racial difference, you can read about it, in Joe Graves' excellent book, among other sources, but you can also read it in the news. You can also read it in coverage of what has been happening to American medicine as a consequence of Donald Trump's racism and the nonsensicality of so much of what RFK says, which, as we just heard, can branch out into racial fantasies about different organ systems, such as immune systems in black and white people. So that is one big point I'd like to make today, and I will ask for the advance to the next slide. All right, this is from January 2017. I gave a talk at Florida State University. This is a poster advertising the talk, the Martin Luther King Jr. Dare to Dream Festival. This was put on by White Coats for Black Lives. The dean had no interest in doing this. It was activistically inclined medical students who did this. They they scheduled a 5-day program on race and medicine at the Florida State University Medical School without the interest of the dean, which tells you something about the power politics of American medicine, in this case, in one medical school. But the American medical schools are very similar, with the handful, the exceptional handful at race and medicine instruction in medical schools it's hardly there. I tell my students in my undergraduate course that after 14 weeks of a semester in which they study race and medicine with me, they're going to know far more about race and medicine than any medical graduate in the United States, not to mention a vast majority of medical faculty. That is how bad the situation is when it comes to the neglect of the racial dimension of medicine by American institutions, whether it is medical schools or health and human services, with or without RFK, et cetera. So these were the people. These were medical students of color who did this. The next slide, please. And there they are with me at the center. These are all quote unquote minority people. All of them were participating in a bridge program whereby if you don't have college grades that cut it for medical school admission, you do an extra year of science, and then you do cut it and you get into medical school. I looked up some of these people years ago. They're doctors, all right? So imagine in the Trumpian world in which DEI is a taboo, would this have happened after January of 2025? Okay, this again is the racial politics of medicine, one aspect of it. Okay, could we have the next slide, please? What is a racially pathogenic society? What I'm going to claim that American society, I mean, I've been doing this for 30 years, so I'm acquainted with the topic. And one conclusion that I've come to is that there is so much racism embedded in American thinking and social habits and institutional habits that one can go so far as to call American society a racially pathogenic society. What does that mean? It means that potential sources of medical disorders, and I'm talking about plenty of psychological problems as well as organic problems, that potential sources of medical disorders are everywhere. So I mean, this is one way to frame the call it the situation or the predicament of our Black population in a society in which, as we know, the racial health disparities all go in the direction of Black medical disadvantage. The excuse me, all of the racial treatment disparities, whether it's diagnosis or algorithms, et cetera, they all produce Black medical disadvantage. And so that this is, I've just been talking about a big political frame, a big medical political frame that I think we need in order to understand what is going on since Trump's anti-DEI executive order in January of 2025. That is one big frame. Here is another big frame where it is very, very difficult for the Black population not to encounter pathogenic circumstances, experiences, and that, of course, has a lot to do with racial racial health disparities. So structural racism is a very widely used term. I think it is used too often and often too vaguely. Structural racism, as I understand it, refers to arrangements that pertain to the larger society or to arrangements according to which one runs a hospital or one runs a clinic, that it's set up in certain ways so that as to produce Black medical disadvantage. One example of this that comes to mind, and of course this is embedded in social inequality, and that is the so-called use of lower use hospitals and higher use hospitals for surgical procedures. The lower use hospital is going to mean that the surgeons we're talking about surgery in this case, the surgeons are going to have less experience and they're not going to do as well. The wealthier people have access to so-called higher use hospitals in which they're going to have better surgical outcomes. Now, of course, this has a great deal to do with the socioeconomic circumstances of Black populations as opposed to white population. I'm generalizing, but you'll see this low hospital scenario reported in the literature multiple times. That is an arrangement, is a nice generic way to call it. It is an arrangement that is going to produce Black medical disadvantage. Okay, could we have the next slide, please? All right, this is research. This is all, I think it's all peer-reviewed. MedPage Today is a quality piece of medical journalism. I've got some from there, some from other journals. The point is that I've got a list of 50 of these. And what you do is in the left-hand column, you put some sort of societal phenomenon, to put it very generically. And then on the right-hand side, you correlate, or you try to correlate, or you presume there is a correlation between the large societal phenomenon that could have to do with, Medicaid coverage, unemployment, the Black doctor population of a certain county. And the attempt by these researchers is to correlate these large circumstantial phenomena, the societal phenomena, with specific medical disorders or conditions. And so, if you read down one, two, three, Medicaid coverage, which of course is important, gastrointestinal cancers, they have established or they're trying to establish a cause and effect relationship. Unemployment and sickle cell pain, that seems plausible to me. Here's a very interesting one. If you put a slightly greater percentage of African American doctors in a county, the health metrics for the Black population are going to go up. It's mysterious, but apparently it's true. And so that it is, in this case, it has been correlated with longevity. Okay, could we have the next slide, please? This is more of the same. It's the same framework here. Neighborhood deprivation is your large societal phenomenon. Structural, well, all right. Household income, they have established or are trying to establish a correlation with severe retinopathy. And the list goes on for 50 of these cases. Could we have the next slide, please? All right, more of the same, and I think we'll cycle through more. All right, and then I think there's another. Okay, here is the report that in counties with more Black doctors, Black people live longer, an astonishing study finds. It must, you have to speculate about a scenario like this. It must have some kind of psychological advantage or a boost in one's general disposition, in the direction of optimism, whatever. It is not surprising to me that this finding exists. Could we see the next slide, please? Here is another example of a Black medical disadvantage, Black pregnant women being tested more frequently for drug use. A study suggests, 25 years ago, was it? Longer than that. I gave an independent study course to a young Black woman at UT as an undergraduate who has now been a neonatologist for many years, is thriving. She told me one day that what she was tested for was STDs, and that apparently there was a bias there. This was an eminently respectable young Black woman, but she got tested. She got tested because she was Black, and the presumption was that there was inordinate sexual activity exposing her to greater risk of STDs. It seems like a small thing, but it isn't. The more frequent drug testing for Black pregnant women is well known, and it's demoralizing. It's insulting. It is, when you think about it, it is ascribing to the Black woman who shows up for treatment some kind of an association with, sexual misbehavior or promiscuity, whatever it is. What I'm saying is that these aspects of Black medical disadvantage, which is the category to which I would assign this one, they're countless. They're countless. In a racially pathogenic society, Black medical disadvantages are going to be created at every level in ways you can't even imagine until you find them. Could we have the next slide, please? All right, maternal mortality we have already mentioned. It is a continuing, scandal or whatever you want to call it. The medical establishment seems to be making efforts to do something about this, with Black women dying something like 3 times more frequently by proportion than white women. I mean, it's an open scandal. ProPublica did a wonderful article on this a few years ago. The famous case is Serena Williams, where she had to instruct the doctors who were ignoring her complaints about what to do so that she could survive. She saved her own life. The number of reports of Black women in particular, and not just in these birthing scenarios, being disregarded. There are many, many reports of that. This, call it structural. There's something wrong. I mean, this is an arrangement that is accepted, and enough is not done about it. Okay, next slide, please. Few sickle cell disease patients are adequately treated for pain. Under 4% of patients have prescriptions for appropriate drugs. The point that I will pull out of this one is that the whole subject of pain is the relationship between Black people and pain is a piece of racial folklore that has been around for a very, very long time. And there are all sorts of scenarios in which Black pain, or the intensity of Black pain, is discounted. The go-to article to document this, I think this was in the proceedings of the National Academy of Sciences, is the Kelly Hoffman article. She was a grad student. The Kelly Hoffman article from 2016, where she documents this unmistakably. And she also talks about the kinds of racial stereotypes that many, many medical students are carrying around in their heads as they get their medical educations. Belief in immunity to pain, belief in tougher skin that's harder to injure, et cetera, et cetera. Racial fantasies about racial differences in lots and lots of our medical students, and very little is being done to correct that. All right, could we have the next slide, please? Now, this is a very important topic, and I will bet you that when I get further into Joe Graves's book, he's going to have a lot to say about this. Weathering is it's a theory, but it's a true theory, and that is that excessive stress on the human organism is going to weather it, and it's going to wear it down. It is going to produce more cortisol that does harm, et cetera, et cetera. It's a whole systemic sort of physiological phenomenon in human beings who are exposed to too much stress. And what my experience tells me regarding the African American population is that there is hardly a more important concept than stress to account for all sorts of medical problems, conditions that Black people deal with. This is the famous Arlene Geronimus, first introduced the theory in 1990. Her ideas were derided and largely ignored. Now, this is standard fare. And as I said, Dr. Graves is going to probably have a whole lot to say about this. in why Black people die sooner, which reminds me also of another, as a matter of fact, even the part of his book that I've read so far, he mentions, and this is not well known as far as I can tell, accelerated aging, aging faster. The Black population ages faster than whites. This has been demonstrated with studies of telomeres that can indicate the rate that aging is going on. So this is a really important concept in the study of race and medicine. The next slide, please. All right, racial health disparities. Could you advance the slide, please? We've all seen these bar graphs. There are many of them. People of color fare worse than their white counterparts across many measures of health status, and that's a fact. That is what they call racial health disparities. Could you scroll through the next slides that we don't need because yeah, and the next slide, please. All documenting the same thing. All right, now we come to racial treatment disparities, or what I will call, and you notice I don't use the word racist very much. I know, I mean, studying the medical world, nothing can establish a reality of systemic racism in the United States better than studying the medical journals. All right. It's not that I'm, allergic to the word racist or racism, far from it. But I think it's very important to use it in a careful fashion so that one doesn't slide into polemical verbal formulas or attitudes that are going to shut down the conversation. So I could say racially treatment disparities, I could call that, quote unquote racist, which is, one of these words. It's like the word hate or hatred for anti-Semitism. It's not very helpful because there's lots of discrete things going on in people's feelings about Jews. And just referring to it as hatred is, it's just anti-scientific. I think the same principle applies here. I would rather talk about racially motivated diagnoses or treatments that can cause medical harm. I would rather call it racially motivated rather than quote unquote racist, because it is generally agreed that when doctors, and I'm talking primarily about the white doctor population, misses a diagnosis or prescribes a mistaken treatment that is not going to be to the medical advantage of the Black patient. I think there's general consensus. These people don't mean to do harm. I'm guessing it would be very hard among the million MDs in this country to find people who want to do harm to patients of color. It is rather the mindset and what they have been taught in medical school and by colleagues, the hidden curriculum, as it is sometimes called, in medical school, where it's informal, but older doctors will tell tales to younger doctors, for example, about Black people. So racially motivated diagnosis treatments cause medical harm. There is a long list of them that our time is flying. We don't have time for. Let's see. Could you advance one slide, please? This is a very long list of treatment disparities, withholding organs, et cetera. Pediatric kidney transplants, opioid use disorder medication, chronic hepatitis B virus initiation. I'm holding my hand a couple of dozen more that I will not have to recite. So there's this huge difference between the health disparities that are produced by huge social factors, as well as medical factors that are dysfunctional, often dysfunctional in the assessment and the treatment of Black patients. Don't take my word for it. It's all in the medical literature. That's where all of this comes from. Could we have the next slide, please? Here, well, pulse oximeters produce false readings for Black children. Well, they can, pulse oximeter, the thing that they stick on the end of the finger to get the oxygen level, can produce false readings for Black patients, period, because the amount of melanin in Black skin is going to distort the reading from the oximeter. This is well known, by the way. I mean, nobody tried to manufacture an oximeter that was going to disserve Black patients. It just happened. And so then the question, and if you're dealing with a COVID patient for whom the oxygen level is absolutely crucial, it's a life and death matter. It happened by accident. And then the accountability question is that who's going to do anything about it? I think they're doing something about it, but it's an odd case. By the way, this is the PNAS paper from 2020. Black newborns die twice as often, was cared for by white rather than Black physicians. This paper was retracted for false methodology, which is very good news. That was a sensational piece of medical news in the American press several years ago. And then a few years later, it had to be retracted because the methodology was faulty. But I guess the tiny silver lining I'm going to pull out of this or inform piece of information is I found it very easy to believe this headline, although it wasn't valid. I have been conditioned over many years of studying the racial dimension of medicine to expect habitual white bias in all sorts of areas. And so that I fell for this one. And then I was glad to see the retraction a few years later. Could we have the next slide, please? All right. Now, this would be an example of a racial treatment disparity. And as I said, there's dozens and dozens of them. The next slide, please. Black and Hispanic patients with terminal cancer receive fewer opioids for pain, new study finds. This is 2023. I am frankly surprised. The Kelly Hoffman paper that documented to everybody's satisfaction, according to a scientific methodology, that this was happening, and that patients of color were getting less pain relief than their white counterparts. The question I have for the medical establishment in cases like this is, what are you doing about it? I don't see any sort of institutional process for remedying these situations. The question is whether, the medical establishment, in quotes, this enormous social organism, the medical establishment, has any sort of organized way in educating doctors that these things are happening and promulgating standards or checklists so that it happens less. As a matter of fact, one way you can reduce maternal mortality is you can put up a checklist in the relevant hospital room in which you gotta do these 10 things. You got to do these things so that nobody in that room is going to forget number 7. And that is going to be the advantage of the maternity patient, no matter what her ethnicity happens to be. Now, what I just noticed is that we have a maximum of 30 minutes left. And we would really like to have substantial questions and discussion. And so I'm going to ask Priska, who is going to administer this, to begin if she thinks it's appropriate.
All right, let's see if we have any questions. Like Dr. Meyer said earlier, I'm gonna answer questions from my colleagues in the HAPI program first, and then we'll move on to the general audience. Let's see. So while my colleagues are gathering questions, I can go ahead and ask one. So from a health policy perspective, what would you prioritize first? Improving access, changing provider behavior, or addressing broader social determinants, and why?
It would be changing provider behavior, and which is the hardest thing on earth to do. White doctors do not want to be told that they are racially biased. In fact, some of them are outraged by the idea that they are racially biased. And this is an opportunity, by the way, to point to an important phenomenon in the medical world that has evolved over the past 10 years or so. And I'm talking about the anti-woke medical campaign. The most prominent actor in this scenario is Dr. Stanley Goldfarb, formerly a professor at the university. Well, as a matter of fact, he was assistant dean at the University of Pennsylvania Medical School. And Dr. Goldfarb, for a long time, has been running a website called Do No Harm. And this is a doctrine. It is a doctrine that says that claims of racial bias in medicine, medical racism, vastly exaggerated, that white doctors are largely immune to, racially motivated, as I put it, attitudes that are going to produce Black medical disadvantage. This all started 26 years ago when a psychiatrist named Sally Satel published PCMD, Political Correctness, Medical Doctor. And she established she's a smart person who's got it wrong and has been publishing for the last 25 years. Essentially, say she has a whole coterie of acolytes who admire her, who reproduce her ideas about how the white medical establishment is hardly vulnerable to acting out racial bias in the form of medical behaviors. So that is a very important thing that's going on. And as a matter of fact, it is sort of the more gentrified version of the medical racism that you'll see in Trump and RFK Jr. But the key here, or one of the keys, is medical school. And I mentioned at the beginning that, as far as I can tell, I've taught this stuff at least for a few years in a medical school, and today it would be politically impossible to do that. Um, you you have to introduce a race and medicine curriculum into medical education that means something. I mean, at the risk of boasting, my undergraduate course on race and medicine should be in every medical school. That means you have to pay attention to who's running the medical schools. And the deans of American medical schools tend not to be very interested in the racial dimension of medicine. So it's a very difficult situation. Now, white coats for Black lives, whose picture you saw a while ago, I looked it up online. They're apparently still surviving in American medical schools. which half surprises me. I'm glad they're still there and that the purge has not reached down to organized activity by medical students. In this case, it's going to be mostly medical students of color. It's a very, very hard problem. And when you have at the top of the government an openly racist person who is going to, trickle down his racist attitudes into everything. This is an additional circumstance that makes things even more different. And that is why I refer to the beginning that there's sort of two eras in which I've been giving talks like this. The era before the second Trump inauguration in January of 25, and after. And as you've heard, I don't think it is responsible to talk about the racial dimension of medicine without pointing to the enormous and obvious political dimension of all this. Conveniently represented by RFK Jr., who, in addition to the damage he's done to vaccine administration, is blurting out these unscientific racial fantasies about black bodies. Okay, it's a tough situation. That's the best I can do today.
Thank you so much. It looks like my colleague, Jero, had a question in the chat. Jero, do you mind reading your question?
I don't mind at all. Thank you so much, Dr. Hoberman, for this presentation. My question is, given the current backlash against DEI and the politicization of public health, how can institutions meaningfully repair trust in communities that have historically experienced medical racism, especially when leadership itself may be disengaged or resistance? Like you mentioned, the fact that the dean was not even able to participate in that event that the students organized. What does it tell for the next 4 or 5 years within the current system?
Are you referring to what when you say institutions? Do you mean medical institutions?
Yes, I mean medical institutions and universities.
Well, one of the sad things that is happening today is that the leadership of medical institutions are not showing much courage. And I mean, take for example what I read before that 46 of these osteopathic hospitals have sworn that they're not going to do anything that smacks of DEI. Even before the imposition of Trumpian ideas and methods, the performance of American medical schools, there's about 150 of them, has, in my judgment, for what it's worth, been very poor in the sense of, in one of the great traditions of American medicine has been to neglect and ignore the medical needs of the Black population. And that is the context in which medical schools have developed. And so it is hardly a surprise that American medical schools, even in a country with 48 million African Americans, they're just not interested in doing anything serious. There's probably good things happening at Duke. There's a medical school in Canada, actually, that has quite a robust program because the indigenous population of that area of Canada insisted that medical education in that part of the world was going to address the needs of a non-white population. I mean, that's what it takes. But the academic institutions, in the face of the Trump attack on universities, there's been very little courage shown. The president of Harvard has done quite well compared with his peers. The president of Wesleyan University a couple of years ago, he did himself proud. He was the first of the presidents to directly resist Donald Trump. So, I mean, forgive me, but I don't have, I don't have a really good answer to this question, because what I'm claiming is that you have to have racially enlightened medical schools, which means you have to have people at the top, like deans and provosts, who understand that that the medical predicament of the African American population um, is a kind of a calamity. And I'll tell you something, slightly anecdotal. I was consulted on a story that ESPN, the sports broadcaster, did last year, and they have some serious reporters there, and so one of them called me up, and what he told me was that they had done a study of all the NFL players who had played in 1987 or something like that. So it was standardized, it was done responsibly. And what staggered them was the health status of the retired black players compared to the health status of the retired white players. And what is our image of black sports stars? They're rolling in money, Ferraris and all the rest of it. That is not where it's at health wise. That this was Mark at ESPN. They found all sorts of adverse medical conditions and outcomes in the black population of NFL veterans as opposed to the white ones. I say this in order to reinforce a point I made earlier, and that is that in this society and the medical system that serves it, black medical disadvantage is everywhere. And the image of the retired player who's been paid millions, etc. No, you have to look at the NFL situation through a public health lens. These are people. These are people. These are black people. And that means that the expectation is going to be that they have suffered all sorts of black medical disadvantages. It's everywhere. I'm sorry I couldn't do better, but that's what I have to say.
Thank you so much. That's enough for me. Appreciate it.
Thank you.
Let's see. Any questions? Well, everyone's still kind of forming a question. I can ask another one, kind of going off my last question where you said changing provider behavior should be priority. What are some current ways that medical training could better prepare physicians to recognize and avoid this?
Are there? What is your question to me? Are there ways in order
Yes.
to better educate physicians about the racial dimension of medicine?
Yes.
Yes, there are, and once again, I'm ashamed to say it. I would point to my own undergraduate course. Okay, the question is, who's going to be interested? Who is going to be interested? Where, medical administrators have all sorts of reasons to turn down creative suggestions. One of them used to be, oh, we don't have time in the curriculum for things, about, the social aspects of the practice of medicine. We invest our time in training people to be expert at life-saving procedures. How dare you displace courses that are going to provide medical students with, expertise in life-saving, with something as vague as, the social dimension of medicine, which, is profoundly ignorant the the social circumstances, I mean, anybody knows this. The social circumstances in which people live are enormously determinative regarding what kind of health experiences they're going to have. It's
Thank you.
it's a terrible situation that Trump has made worse. But he's not around forever. And I'm looking forward to a period of reconstruction, if you'll pardon the word.
Thank you so much for that. It looks like Dr. Myers has a question.
Sorry, I was hoping one of the students would raise their hands before it came to be my turn, and I'm still hoping that they'll participate a little bit more here. So, having gotten that nudge in, um, one of the striking things about the field of race and medicine and its development is that, the work of Dr. Graves and others showed clearly that, and going even Craig Ventnor showed that race is really a social construct more than a scientific reality or medical reality, and so that can have all kinds of implications in terms of research and clinical care, et cetera. In the clinical arena, I think the direction that's taken the field is that, you don't look at somebody as a race, right? You don't start out a medical encounter with note by saying this 48-year-old African American male, da 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 da, because you've already introduced so much bias just through those first 6 or 7 words. But here's my question. It applies to all kinds of research as well. And when you look at reports or think about these issues, how do you factor that into your thinking that, okay, so these people that are writing these articles may or doing the research may be thinking about race in terms of self-identification or in terms of identification by an independent observer or by who knows what, right? So how do you think about that when you're looking at these broader social questions?
Well, you have to because there's a lot of good work being done, including by Dr. Graves on the quote unquote racial. How do you classify people in a scientifically advantageous manner? And there's ancestry is used. I mean, this is a problem that hasn't been solved. And the fact that I remember reading years ago a 40 page paper in a journal arguing that it's time to get rid of the word race. Well, good luck with that. It's it's a permanent fixture of discourse about human difference for the time being. Anyway, but no, you look at ancestry. There's the self-defined criterion is especially problematic. You go back 20 years to when the drug Bidil was being lobbied for, including by important African Americans, as a heart remedy. They had found this false statistic that you give Bidil to black patients and the heart attacks go down by 40%, which, well, not in this universe. But the point is that in order to qualify for using Bidil, all you had to do was to say you're African American. And of course, the sheer genetic diversity out there is going to is going to foil any sort of, specific designate any specific quote unquote designation of racial identity or whatever you want to call it. It's it's a mess, and the smartest people haven't come up with a definitive system for defining the so-called race of a human being. Now, what we do know, you referred to Craig Ventnor and the Human Genome Problem. I remember this was 20 years ago. Ventnor came out with a very striking public statement to the effect that we've sequenced the genome and race doesn't exist. There's just nothing in there with race on it. There's no such thing as a black gene. There's no such thing as a Jewish gene. Uh, it's hard for people to process.
Yeah, thanks for that. And obviously, it's hard to factor into research on something where the basic premises are suspect, right? Of what exactly is race. I just throw out an anecdote, and no comment required, but Georgetown University had a president named Francis Patrick Healy at one time, and you heard a lot about him and the early presidents of the university. But somewhere in the last quarter of the 20th century, all of a sudden Georgetown started being proud of the fact that he was apparently the first black president of a predominantly white university. Turns out that Patrick Francis Healy was a Jesuit, and he had gone off from his mixed race heritage family and roots and joined the Jesuits. And um, you might say he was passing. I don't know what he said or did about that, but just at the vagaries of what the current societal thinking is about race and what we can be proud of and what we have to kind of sweep under the rug, um, that discussion has changed over the years, and I'm kind of astounded by it. But I hope when Priska gets the mic back that we have some student questions here.
All right, let me take a look. So it doesn't look like at this time we have any student questions. So I'm going to ask one in the chat while everyone can still have a little bit more time to think. So Turner Coggins asked, is the U.S. medical school culture so persuasive that even students of color who have graduated are looking through the same lens as their white counterparts? Or would one have to attend an HBCU medical school to receive a proper perspective?
That is a great question. Um, I, I gave a talk at Meharry once, but I am not familiar with the black medical school scene. Do I think that there, and as ignorant as I am of that particular milieu, would I automatically assume that there would be advantages in uh, spending 4 years at a black medical school? Absolutely. Absolutely. Now, as to the first question, medical school is hard work, and there's a cohort. People have to stick together. It's a hard life for a while. And what I have read is that it is a natural thing that, say, black students or Latino students are going to learn to conform to the culture of the medical school, to learn to conform to the medical learning scene that people in their class, for example, are going to develop and absorb. Is it is it possible for medical students of color to absorb quote unquote white perspectives on medical matters? Absolutely. Absolutely. And I'll tell you a data point that comes to mind. I've seen surveys on uh, measuring what white and specifically black doctors believe with regard to um, the existence of serious racial bias in medicine. And naive me expected that the numbers for black doctors for how do you evaluate the existence of racial bias in medical practice, et cetera, that there would be a very large majority of black doctors who saw it my way. That there's a lot in the racial dimension of medicine that involves black medical disadvantage. I was very surprised to find that maybe even 55% or something of the black doctors did not want to believe that systemic racism was affecting medical practice. So I think that is an indirect way to answer the question as to, whether what happens, socially in terms of mindset to medical students in general. And, we're specifically interested here in black students who are not immune to absorbing the mindset that is taught in medical school, which is going to involve a lot of neglect at important black medical issues.
So if I can just also make a comment regarding my colleague Turner Coggins' question. I taught for 40 years in one of these bridge programs that you mentioned, John, at Georgetown University. And so, I think that part of the answer to the question, and you're not answering in this context, I recognize, but part of the answer to Turner's question is it really depends on the individual medical student, right? And there are lots of medical schools, and students should figure out which ones are going to be best for them and train them in the way they want to be trained. But we've had students in that bridge program who felt that they needed to go to a HBCU medical school to achieve their self goals and meet and be consistent with their idea of these topics. But at the same time, we've had a student who went to Georgetown University Medical School and became president of an HBCU. So it's an individual thing as well. So sorry for my interruptions, John, but it's one of my favorite topics. I'm so happy you're here today to answer questions, and I hope there are a couple more, and I'll turn it over to Prisca to tease out those questions and take it away to the end.
All right, so looking through, it doesn't seem like anyone has any more questions. So thank you so much for joining us today, Dr. Hoberman, and I'll turn it back over to Dr. Myers.
Okay, so I remind everybody that we're reaching the end of the HAPI program and this year's seminar series as well. We have a talk next week by a researcher who was a student of ours years ago and is doing public health research. So please join us for what's going to be the last seminar of this program next week. And I want to give a special shout out to John for coming back today and giving this important lecture. You saw from his title slide that he's given this talk not only to this series, but to one of our programs that we started over at George Mason University. He's really been a friend of our programs. So we'll have you back in a couple of years, maybe at this at this new HAPI seminar series that we're going to start next September. And we'll welcome back everyone to those. You'll be getting notifications about it well before it starts. So thanks to everyone and have a great day. Any last words, John?
Thank you for this opportunity.
Keep up the important work. Take care, everyone. Good afternoon.